So today we're going to be talking about COVID-19 in the skilled nursing facility. This is sort of our ongoing series that we've been having regarding the nursing homes and all of the different challenges that they're having with COVID-19 and all of the weekly sort of updates and continuous changes that are occurring in real time for the skilled nursing facilities. We did not do a webinar last week, and that was really to give a chance for the facilities to sort of catch up on all of the things that we were talking about that were happening. And now, all of those things are sort of in place. So I wanted to give us an update on the regulations some of the regulations we discussed last time and where we are now with it and what the federal government has done. And then also start talking about some of the clinical presentations associated with COVID-19 that we're all starting to see or will begin to see if you haven't already regarding patients that we're managing that are COVID positive or that are status post-COVID positive or COVID positive suspected. And so let's review those at the end as well, and hopefully you'll enjoy that presentation to give you some insight on maybe some of the things you've seen that you didn't realize that might have been COVID related. So let's get started. So first of all, just a reminder to everyone, it is Nurses Week. So please reach out to your treatment nurses, your DONs, your CNAs, your charge nurses, and just tell them thank you. Thank you for all of their hard work, all of their effort, all of their energy. It's a big deal. Celebrate with them, join them for lunch, participate in whatever activities they're having in their facilities. We are part of the team, and so we're never outsiders. We are insiders when it comes to our skilled nursing facilities. So you want to make sure that you celebrate your SNFs with them, especially considering this crazy time that we're in and that the skilled nursing facilities are in. And so, they need that positive boost that you bring when you walk into your building. So please do so. Here's an example of Dr. Shaniqua Scarborough, who, she sent her facilities, and this is specifically Sacramento post-acute, she sent her facilities bagels and coffee, and look what they did for her in response, and text back to her, making her a huge sign saying, thank you, Dr. Scarborough, for the Starbucks, and that they're thankful for her. And they sent her a lot of images and pictures just saying thank you. And so your facilities really do appreciate you more than you believe. We know sometimes things get a bit stressful or so busy with all the patients we have to manage or all of the challenges that we're dealing with on a day-to-day, but don't forget to slow down and say thank you to your nurses. And just, doing a little bit of something for them will go a long way in building relationship, which is one of our core values, building appreciation, building trust, and building a team effort and a team component in your facilities. So thank you, Dr. Scarborough, for sharing these images, and thank you for reaching out and taking care of your facilities. They truly appreciate it. And by the way, facilities do call me and text me and reach out and just tell me how great of a providers that they have and saying thank you, and also threatening me to never change their provider, because if they do, they'll be very upset. And so I always appreciate those types of calls because it really means that you guys are doing an awesome job out there. So keep it up, but please thank your nurses and celebrate with your facilities, okay? All right, so for today, we are gonna be focusing on two-parter. The first part, we're gonna talk about regulations, CMS and CDC regulations and updates there. And then after that, we'll talk about some clinical associations with COVID-19. All right. So I'd like to begin my discussion today talking about New York, using New York as sort of our discussion plate, so to speak, or our lead in our discussion. As you know, New York is really the epicenter for the COVID crises, with them having the most amount of outbreaks, most amount of positive patients, or positive cases rather, as well as the most amount of deaths. And so I wanted to use them to start off with, and more specifically, because there was a recent development that Governor Cuomo had announced on Sunday regarding changes to the previous policy that was initiated two to 3 weeks ago regarding admissions of patients into the skilled nursing facilities that were COVID positive, as well as screening protocols for skilled nursing facilities. So let's kind of go over a summary of that. So many articles were released over the last few days about Governor Cuomo's announcement. One of them stating hospitals cannot discharge COVID-19 patients to nursing homes, and nursing home staffers will be tested for viruses twice a week. So this was a big deal because it was a huge shift from previously where all nursing homes were mandated to admit COVID positive patients. And many nursing homes really committed to the challenge and converted their facilities to COVID only facilities. And so him making this sort of quick change created a lot of craziness and sort of discourse within New York, and trying to figure out how to adapt to the changes that he's making, because people are frustrated with the level of testing they're going to have to do. And then also financially, a lot of hospitals that were discharging will not be discharging, and a lot of nursing homes that were expecting, that created and cleared beds and discharged patients away that were COVID positive, that were COVID negative to other facilities in an attempt to take care of COVID positive patients, now won't have them, so they're financially affected. So there's just a lot of challenge with this, and some of this is because there was a lot of accusations that the increased numbers in New York nursing homes were due to Governor Cuomo's mandate of nursing homes having to take COVID positive patients, even though they might not have been ready for it. So either way, we're using this as our foundation for our discussion. And this is important because we have a lot of providers on the East Coast, and I thought it was important that we go over a quick protocol I had to develop on Monday regarding this issue, because we believe that other nursing homes may start to follow suit in other states. And so the summary of basically his announcement was that nursing home staff must be tested for the coronavirus twice a week, and then hospitals can no longer discharge patients to the skilled nursing facility unless they're COVID positive, unless they're COVID negative, and that if nursing homes do not comply with twice a week testing, they will be fined for it. So that's a big deal. And so what we've had to do, because this created a major conundrum, in that if you're like Dr. Smaltz, for an example, or Dr. Vivas, or a few of our other all of our East Coast doctors, you're rounding in multiple facilities a week and multiple facilities sometimes a day. And so would that mean that you literally would have to be tested in every single facility, every single, that you walk in? That would be an overuse of resources, number one, and also extremely uncomfortable to get swabbed that many times a day or per week. So what we had to do is develop sort of a plan around that. And I can send these out to any of the providers who need it, but I did have to send them out to the nursing home so that way they know how we would adjust to it. And so it reads that upon being screened when arriving at the first facility of the week, so meaning, assuming it's a Monday, you're in New York, and you're rounding at your first building, and they've initiated COVID screening starting on Mondays and Thursdays for that facility, you will have to be screened. So you accept your screening, and upon screening, you should take a picture of your lab requisition with showing the date of the swabbing, along with your full name and what the test was for, which should be COVID-19 screening. And make sure you take a picture of that with your phone and you save it. And that way, it becomes basically your passport to enter every other facility for the next 4 days, 3 to 4 days. And this becomes important so you're not having to subject yourself to being swabbed and tested in every facility you go into, because they're on a different testing schedule. So hopefully that makes sense. And then what's important to do is that after that, when you go into every facility for, like I mentioned, for the next few days, you will present that image of your actual testing requisition. for your lab requisition rather. And then once you receive your results, and hopefully they should be negative results, at that time, you will then take a picture of that negative result to present to your facilities every subsequent day after. And then, of course, by the third to fourth day, you repeat your test again. And obviously, currently this goes for New York providers, but what we do expect is that most states will go into a once-a-week testing, and I'll explain why that's going to happen as I talk about some of the updates in protocol. So as that does happen, we want to make sure that everyone's aware what to do. It would be the exact same protocol. The difference is you're only testing once a week versus testing twice a week. So at the end, you would just repeat steps 1, 2, 3, and 4 daily, and depending on if you're testing once a week or twice a week. Let me check and make sure we don't have any questions in case. Okay, great, no questions. So it looks like this is pretty straightforward. Everyone kind of understands. If you have questions, please type it in. And so ultimately, the big question is, why is this important? And to really understand, we have to go back a couple of weeks, back to April 19th, when CMS made their first initial updates with mandated reporting for skilled nursing facilities. Skilled nursing facilities have always been mandated to report any infection or specific infection control challenges or positive infections to the state, but never to the federal government. And so with COVID-19 previously, before April 19th, all reports of positive cases were only being reported to the state or at the state level. None of it was going directly to the federal government. But CMS, along with CDC, mandated a new protocol which mandated that all positive cases, along with other suspicious cases, which I'll explain in a few minutes, must be reported to the federal government directly and specifically to CDC through their own web portal. And so specifically, everyone now is involved when it comes to reporting COVID positive patients. And this is really important and critical because if you remember, all the data we've been looking at over the last few months have been really hospital specific data. None of it has really been specific to the skilled nursing facility until the crises happened that we talked about, which was our surge that we talked about. And then all of the nursing homes started having so many positives, and the federal government had to really start to focus and then realize that they were not capturing data. So hence the mandate. And so what's going to happen with this is that as nursing homes report their data to CDC, the CDC will be able to obviously use the data to implement action plans and support to the skilled nursing facilities. So this presentation I'm giving today, I've given similar versions to the skilled nursing facilities. And one of the things that we talk about with the SNFs is it's important to be transparent and proactive. The more transparent they are, the more proactive they are, the more support that they'll actually get from the government versus hiding cases and not talking about them or not screening appropriately. And then they end up having a bloom of positive cases in their facility. So ultimately, though, this information will be posted to the public. So that way everyone is aware of every single facility that's COVID positive in the United States and how many cases they have and what the data and metrics are for those positive cases. So let's fast forward a couple of weeks now from April now into May. And as of last week, May 8th, the federal government then basically began the initiation of their mandate. And that mandate was that every facility in the United States has to report specific criteria for COVID positive, COVID suspected, and symptomatic patients, and also death. And that reporting was supposed to begin as of May 8th, and it's supposed to end as the first round is supposed to end as of the end of this week, Sunday, May 17th. Now, this is supposed to be ongoing until further notice. So nursing homes are supposed to basically start reporting in real time, daily, as these occurrences happen in their facilities. And so what must they report on? Number one, they must report on residents and staff who are suspected of being COVID positive. These are otherwise known as persons under investigation. They must also report on residents and staff that are obviously confirmed COVID positive. They must also report on residents and staff that have severe respiratory infections resulting in hospitalization and or death. So really important. And then lastly, they have to report on any residents or staff, any combination of 3 or more residents or staff that have new onsets of respiratory symptoms within a 72-hour period. So that's really important. And then recently, as of this week, they made updated modifications to this exact protocol that we're looking at here. And I'll go over that a little bit later. So like I mentioned, as of the 8th, every single nursing home in the United States must report directly to CDC. They still have to do their state level reporting, but now they have to report directly to CDC into their portal, answering a list of questionnaires, questions that are listed within that portal. And so CDC reporting, it will be is mandated as of now. And so all of this plays into CDC's and the federal government's surveillance system and plan that they have in place, because they need to make sure that they're capturing as much accurate data as possible. And they know that the most highest concentrated patients of at-risk patients are located in the skilled nursing facility. So they want to make sure that they have accurate data there. And so they really are pushing for the skilled nursing facilities to cooperate. And if they don't, they risk being fined and cited. And we'll talk about that a little bit later. So as they mentioned, the importance of the ongoing transparency and information share has proven to be one of the keys to battling against a pandemic. So literally what they're saying is that it's so important to be able to have accurate data to be able to fight the pandemic. And so nursing homes must comply. And the report or the data that's being collected will go live on CDC's website starting the end of May. So when we do our webinar sometime at the end of May or beginning of June, I'll have all of that data and we'll be able to share that with everybody. So a few things should have happened in your facilities by now if it hasn't happened already. And if it hasn't happened already, it will be happening sometime this week. And that's that mandatory testing for all will be in place, meaning that one of a few things would have occurred. Either by now, most of your facilities would have had the state surveyors come into the building to perform COVID-19 testing on every single person in the building. That includes residents and staff and us if we're in the building. I think we talked about that at the last webinar. If they're screening, accept to be screened. Really important. Do not say no. It's very, very important that we always accept to be screened if there's a screening going on, unless you were just screened in a building prior. The National Guard would have been in one of your buildings screening patients and residents, and then also offering deep cleaning for that facility. And then lastly, which is happening in some cases where CMS literally or the state has shipped all of the screening tools to the SNF, and then they're telling them to do the screening themselves and then submit all of the assessments to a diagnostic company that CMS has designated as a diagnostic lab for them. So one of these 3 scenarios should have occurred in your building either already or it will be occurring sometime this week. So you should ask your buildings, hey, have you guys started screening yet? And if not, because there are going to be some late entries, expect that it will be happening sometime soon. So there has been more updates to the original 4-part requirement by CDC for reporting, and let's go over that now. And so that more, those, and by the way, one of the things they write is that even though now there's 8 or about, I believe it's 7 total requirements, that they most likely will be adding more in the near future. So number one being facilities must report directly to CDC any suspected and confirmed positive cases of residents and employees, and also include any previously treated positive COVID cases directly to CDC. They must also report on the total number of deaths that are due to COVID-19 for residents and staff, and also those who the facility may have discharged to the hospital and then they died in the hospital. So those are supposed to be included there as well. And also now they have to report on their PPEs. Remember, we've been talking about the skilled nursing facilities have to start implementing use of PPEs. So they have to report, do they have enough PPEs? Have the facility and staff been using them? Do they have enough hand hygiene supplies? That includes antimicrobial hand sanitizer, as well as soap and water in sufficient areas. They need to report on that as well. And also for any facilities who do have ventilator capacity, they must note if they do and if they have enough supplies within their facility. And they must also report on what is their current number of beds available for their facility and what is their current census. They want to know, are these beds empty or do they have a full house? Also, they must also report on access to COVID testing. In other words, have they received their test? Or did they get any support from their local government? Or are they paying for tests? Or are they short on tests? So they want to make sure that every nursing home has a sufficient amount of tests, but to do so, they have to report whether they do or not. So that's also required. And then nursing shortage is a huge deal. Last week, the federal government released even more waivers to allow nursing homes to have more nursing support. And so they really want to make sure that nurses are available to skilled nursing facilities. So they're asking for the skilled nursing facilities to report that data as well. And then I know I said there was only 7, but number 8 is really not a designated requirement. It's basically, it's an open page saying that the Secretary of State may be adding more requirements as needed. And so we expect that they will, based on the reporting and based on the information that they've given on their sites. So the information will be posted publicly by CMS. So literally, CMS will be posting all of this data on every one of their public sites, everything from Instagram to literally nursinghomecompare.com to any other outlet. And of course, CDC will be doing their own, because they want to make sure that the general public has all of the information and they know exactly what's going on in every single nursing home when it comes to COVID-19. One of the other requirements that was updated was the requirement that facilities must inform or notify, rather, every single resident along with their family members or any of their representatives when they get a COVID positive patient in their facility, or when they have a suspected COVID positive patient, which is a person under investigation, or lastly, when they have 3 or more persons that are symptomatic that potentially are COVID symptomatic or have respiratory symptoms rather over a 3-day period. So they have to inform all of them and record that. And they must do it by 5 p.m. the next day of the discovery. Really what the initial guidelines gave them is within 12 hours, and if they don't do so, they will be fined. Okay. So one of the other updates to the notification guideline is that they no longer need to report the name of the person who may have been positive or who they may be suspicious of. They only need to inform that we have a suspected case or a positive case in our facility, but they do not need to say the name. But they must include in every report information on any mitigating actions that were implemented to prevent or reduce the risk of transmission. And so that's really important because every facility, when they set up an infection control protocol, need to do weekly QAPIs, meaning that they need to reassess their guidelines and make sure that it's still relevant for the population that they have and for the circumstances that they're dealing with. And so they have to report on that weekly as well. And also always include any cumulative data, meaning last week we had 1, this week we now have 2, which is a total of 3, and they have to continue to do that on and on and on. So they have that total number of patients in or cases that they may have in their facility. So another requirement. Let me check and make sure there's no questions as we're going on. Awesome, no questions. All right, so obviously all of this reporting that the nursing homes are going to have to do will bring a tremendous amount of anxiety. That level of anxiety is what actually kept a lot of facilities from not wanting to report cases in their facilities at all. And now that it's mandated that they need to report directly to the federal government, they can no longer abstain or deny or delay that information. So one of the biggest concerns is, will they be penalized when they self-report all of these cases? And so CMS specifically writes that they will not use the data to penalize nursing homes for the presence of having COVID-19 patients. And this was important because nursing homes don't want nursing homes to hold back for fear of retribution or being afraid that they're going to be penalized for reporting that 90% of their staff and residents are positive. And as we can see from some of the data we reviewed last time, it's not unusual. So, but the caveat is CMS still has their surveyors who will still be doing their job, which is to go out to every single facility in the United States and assess to find out if the nursing homes are implementing and establishing a good and appropriate infection control, prevention, and education protocol within their system. And if they do not, then they risk basically being given or cited an IJ in their facility. So that is not going away. You can report, but if you don't have good infection control protocols, then you're still going to be cited and potentially fined as well. And so, so that's an important component to keep in mind. And so when it comes to reporting, CMS has set up some dates and guidelines and penalties associated with it. And so as we know, as of the 8th, reporting was supposed to start, but they know that a lot of facilities aren't going to report on time. So what they did was they initiated recently this week a 2-week grace period, giving everyone until the 24th to start reporting. And so if they do not report by the 24th, they will get a letter warning them that they must report to CDC directly, and it must be done by the 31st. If after the 31st they do not report, then the fines start to kick in. At that point, they must report within the CDC web portal, which is called the NHSN system, and fines start to accumulate at that time. So the accumulation of those fines are $1,000 per day in civil penalty for failure to report each case. So it adds up really, really quickly, and it's a retroactive addition. So meaning that after the 31st, it starts to add up per day, per week. And it can get really expensive, and every week it increases by $500 per day per week. So week 1, it's $1,000 per case. Then week 2, it's $1,500 per case. Then week 3, it's $2,000 per case. So sequentially, it gets very expensive, and it can end up costing the facility thousands of dollars and potentially hundreds of thousands if they're not careful in fines. And so that's really the big deal when it comes to actually reporting. They're gonna make sure that the facilities report. So when the surveyors do come into the building, specifically for infection control assessment, they're gonna be looking for 3 specific federal regulatory tags. FTAG 880, FTAG 884, and FTAG 885, and then the subclass E0024, which basically CMS and CDC, and then of course DHS will be enforcing. And I'll explain to you what each one is in a few. So FTAG 884 is reporting. Are you reporting directly to CDC through their web portal, or are you not? If you're not, you will be cited heavily and you will receive an IJ. Under FTAG 885, are you notifying the residents, the families, their representatives, and your staff of any suspected cases, positive cases, or suspicious symptomologies that are occurring within the facility? If that is not done appropriately and documented appropriately, the facility will be cited for that as well. And then lastly, under FTAG 880, this one has been ballooned into a more comprehensive FTAG, where now under FTAG 880, it's your complete and comprehensive infection control protocol, implementation, and education program. That includes everything from hand hygiene, appropriate use of PPEs, as well as environmental cleaning and disinfection, as well as any processes for reuse of residents' medical equipment, and as well as also any transmission-based precautions when necessary. So meaning once you start having to split your facility into one ward for COVID positive, another ward for suspected, another ward for negative, are nurses mixing and matching wards, what they're not supposed to do? Are feeding trays being handled only in each individual ward? And they're looking at everything. When you look at the surveyors guidelines, they're looking at things like, are the nurses holding the trays away from their body and not leaning it on their clothing items? It's pretty serious. And the nursing homes do have a lot to be concerned about, because they really have to implement a tremendous amount of training for their staff, so that way they can be prepared so they don't get cited. So one of the other challenges that's sort of happening right now that we are being caught in the middle of is what I call the blame game. A lot of nursing homes believe that their facilities are COVID negative, or they have low COVID cases. And so they don't want anyone bringing COVID into their building. Let's put it that way. And our challenge and our conundrum, or sort of our problem with that, is that we round in multiple buildings. And so we now have facilities who are calling our providers, who are calling you guys here that are on the line, and they're saying, hey, I heard that you round at building A down the street, and then you come to my building after that. If you're gonna, and they have COVID positive patients. So if you're gonna round there at building A, and then I'm gonna be building B, I don't want you to round in my building anymore if you're gonna round over there. Because you're gonna end up bringing their COVID positive over to my building, and we're gonna have more cases. So this has created a lot of issues where you even have buildings fighting amongst each other and trying to rat each other out, or point each other out, or talk bad about each other, because they believe that that building may have been the building that was the source of the COVID positive patients they have. And a lot of that also, the issue is, they have nurses who work in multiple facilities, and their nurses are working potentially in other buildings that have COVID positive patients. And some facilities have went so far as to even fire or basically let go of nurses who work in more than one building other than their own, even if they're not giving that nurse enough hours or paying them enough, to take care of their family. So this is really unfortunate, because it creates a lot of challenges, when everyone starts pointing fingers. And one of the things that we've been doing with education for the skilled nursing facilities is really talking to them about the importance of being transparent, the importance of being proactive, and the importance of educating themselves and their nursing staff and providing them with support. Because when we talk to them and we explain to them that if you educated yourself and your staff, and you prepared them appropriately, and you gave them the right support and equipment, it wouldn't matter because those were all frontline workers. We all have to see and manage COVID positive patients. But our ability to do it correctly is what's going to prevent the spread of the infection. It's not going to be whether we're working in more than one nursing home. If you have doctors who are frontline or nurses who are frontline in a hospital, all the caregivers in a hospital, they're seeing nothing but COVID positive patients, and they're able to prevent spreading it amongst each other and their families. Why can't your staff do the same? But it's because they just haven't invested enough time in education and in training and in buying the right equipment, or at least speaking with the federal government transparently so they can get the right kind of, they can lobby for the right kind of support for themselves. So that's been part of the challenge. So if that is happening to you, give me a call. We've been talking about it with each provider. One of the quick solutions is pick the building that has the highest patient count or the most procedures, give that facility priority, and then put the other facility temporarily on telemedicine. So that way, you're still able to see and monitor the patients. You're still able to schedule a time when you're going to see that patient, but then they'll know that you won't round or you'll go to their building first. So that way you can go to the second building, the other building second. In most cases, all the buildings are just requesting that they're first. And so, but some buildings go really far and say, well, no, you can't even round there at all, or you can't come into my building. So when that does happen, if you can't round there first because that's not good enough for them, then let me know so we can talk to the building and work it out, okay? Really, really important. Let me look to see questions. Jada writes, just curious, does the reporting requirement apply to assisted livings and memory care units too? Very good question. Technically it does, but they have so far been evading because right now the federal government has been focused on skilled nursing facilities and their ability to report. They mention assisted livings and memory care centers, but they're not pushing hard at regulating or enforcing them yet. But that will come. As they start seeing more positive cases, federal government will be more inclusive in the language for all of the reporting and all of the management of COVID positive patients in those specific healthcare scenarios. So yes, that they are included in the language, but you don't see, they just give them a very small one-liner when they talk about them, and they give them recommendations, but the SNFs are their major focus. And unfortunately, as you know, SNFs get a bad rap, which is why the focus is always there first. Joseph writes, is facilities are making you choose, you are not able to round somewhere, do you document that is the reason why you're not, why you're doing telemedicine? You know, that's a really good question. How do you document that? So Joseph asked a great question. He asked, well, if the facility is telling you that you can't round there and you have to now do telemedicine, do you put that in your documentation? So I would say yes, but you have to be careful how you put it. Remember, we're not in the business of trying to indict our buildings or get them in trouble, because we know that they actually will ultimately get in trouble by not allowing you to round, because you're actually denying the patient quality care. So generally what I always say is call me, and then individually we can work through it. But generally, if you're gonna document something with regards to that, you should just note that currently facility is practicing complete isolation and has limited all essential providers from entry into the building at this time. So for that reason, we will monitor and manage patient by video and voice surveillance or management, AKA telemedicine or telehealth. And then at that point, you continue with your note. So that's the way you'd have to point that in. You don't want to say, well, my patient's getting worse because the facility's not letting me in. You don't want to do that as well. So you want to be careful with the language. And if you need help to create the language, let me know. I'll give you some version of what I just mentioned now. All right, let's keep going. Great questions. So that's it for our regulatory component of our discussion today. I did want to go over that protocol because it's, every week the government adds more, and I want to make sure that we're all on the same page. So we're going to make the shift now from regulations to clinical, and we're going to talk about some clinical scenarios associated with COVID-19. All right, so with that shift, something I think it's important, and I know I've created this slide a while back, and I use it for some of my different presentations, but it's just that constant reminder that we are managing the most at-risk population of patients for COVID-19 infection. You see it in the data. Many nursing homes, when they get it, it runs rampant throughout the entire nursing home, and where you have 90%, 95% positives. And so it's pretty bad because our patient population is just at high risk. And so with that concept of having the most high risk population of patients, one of the things I wanted to look at was who in a nursing home, if everyone is high risk, who is really the most vulnerable for hospitalization and potentially for death. And that's what I wanted for us to focus on a little bit before we move on to another clinical concept. And so with that who, I wanted us to really, like I said, focus on who will suffer the clinical consequences of being COVID positive, which results in pretty much hospital admission and potential death, like I mentioned earlier. And so let's look at who then the most vulnerable population are. So what I did was I did some journal reading, trying to get some data. As we know, there's not much data, but the good part is we're starting to see more articles, and was able to run across a few different ones talking about some different retrospective studies on hospital data, looking at how many patients that were admitted to the hospital, what the demographics were on those patients, and COVID-19 being their cause of death. So one interesting study I wanted to focus on took a lot of data out of New York. And since New York is the epicenter and has the most amount of positive cases along with the highest percentage of deaths, I thought it was a great article to sort of use as a cornerstone to exemplify this concern. And as you can see, New York currently, as of yesterday, so this data is real-time data. As of yesterday, New York had 336,000 plus cases and had over 27,000 plus deaths in the state. And overall, the United States, as of yesterday, had 1,342,000 plus deaths and over 80,000 plus deaths. I'm sorry, 1,342,000 plus cases and over 80,000 plus deaths. Sorry, to clarify. So when you compare that to data from New York, you can clearly see that New York is carrying 25% of the cases and a little bit over 25% of the deaths within the United States. So it's a big deal. So this retrospective study was written on April 20th in JAMA, and I wanted to review that to give us some common information that I thought would be really helpful as we're managing the highest population of high-risk patients in the US. So common comorbidities was really a big deal. Like, who's most at risk, who's most vulnerable to die? And so in a retrospective study, they looked at 5,700 patients that were admitted with positive COVID-19. And it turns out that 56% of them had hypertension, 41% of them were morbidly obese, and 33% of them were diabetic. I call this the triple threat. When patients tend to be diabetic, we already know they're immunocompromised. It tends to make every other comorbidity worse. So you can only imagine you're diabetic, morbidly obese, and hypertensive. Your vascular insufficiency is going to be horrible and really advanced, and you're really, really at risk for obviously getting an infection and potentially dying from it. So that was really an important data and metric that was discovered. And the next one I thought that was really nice, important to share. 14% of the patients that were discharged or that died were treated in ICU, and 12% did receive some kind of mechanical ventilation intervention, and 3.2% did get dialyzed sometime during their stay, and 21% of all of those that were discharged did die. And so that's a really high number considering the case. So upon triage, interesting fact, fever still consistently remains the most common symptomology experienced by all COVID positive patients, then followed by high respiratory rates, and then also by those who needed some level of supplemental oxygen upon their triage admission. So fever still consistently one of the major common symptoms. And I looked at age and sex. So males were made up 65 or 66% of the cases, and the average age overall between males and females was 68 years old, the highest being above 90 years old. And the youngest, I'm trying to remember, I believe it was 18 years old that I on the list. But average age being 68, and the majority being 60 years or older. So being a male above the age of 60 with multiple comorbidities, you're at higher risk for being positive, for getting the infection, and potentially dying of it. So that's really unfortunate. And readmission, something that New York really had good data on was readmission rates for those that were discharged and potentially should have been COVID negative upon discharge. But they found that 45 patients, which is amounted to 2.2%, did get readmitted within 3 days of discharge. And they're not sure why these patients basically started to decline and get readmitted. But what was consistent was most of those patients were ICU patients. And they stabilized, they seemed and appear to be doing well, but suddenly declined upon admission back home. One thing, unfortunately, that I didn't see that I was looking for was what was the associated comorbidity specifically for that population that were readmitted? Were all of these patients, they all have diabetes? Were they completely uncontrolled? Did they have uncontrolled hypertension as well? So were those precursors to potentially that infection, or them just declining again, in spite of the fact that they were still testing COVID negative upon readmission? So in summary, being a male, you're more likely to be hospitalized than a female, especially being admitted into ICU. And then, of course, your comorbidities, which included hypertension, diabetes, and obesity, were those that were highest risk for ICU admission and potentially death. So now let's switch gears and come to the conclusion of our presentation and go over some of the other associated clinical manifestations that has been showing up with COVID positive patients and COVID suspected patients and COVID post-negative patients. So different scenarios where you have patients who were suspected of being COVID positive and developed some of these clinical presentations, or were COVID positive and developed, or after being negative, still presented with these presentations. I thought it was important to review them because we're going to start seeing more of these. As I learn more about them, I'll share, but we're going to start seeing more of them, and we want to be mindful of it and start including COVID-19 as part of an admitting, or as part of our diagnosis as we're identifying these scenarios. And you can free write that into your diagnosis. You can also free write that you believe these symptomologies or that your patient's symptoms may be worsening due to COVID-19 after the presentation that we're going to be talking about today. Before I move forward, I wanted to talk, Dr. Lewis asked, What about facilities that not only lock you out, but refuse telemedicine? Yeah, okay. So before I move on to this, let me answer the question that Dr. Lewis asked. So we do have facilities. We still have in Windsor. We have a few in Texas and in multiple states that lock us out and refuse telemedicine. It's going to be a challenge because once we're back in, their wounds are going to be horrible. And I think we just still have to be careful with the documentation. I think we still have to note that was unable to clinically manage patient due to complete isolation and implemented or enforced by the nursing home due to COVID-19 crises. Now able to see patient has declined, but it's has unavoidably declined due to the current health status of the patient and the health crises that's occurring within the facility, reducing the patient's ability to offload, ambulate, or to mix in general population. So we would be writing things like that when we talk about those patients those facilities that we'll soon be getting back into as they all show up becoming COVID positive. By the way, before I even get into this, I think it's important to note that all of the issues I talked about in the beginning, such as the infighting between facilities, the ones that are locking us out, and the ones that are playing the blame game, that will go away by the end of the month because they would have all been mandated to report. And I'm pretty confident that most of our facilities, if not all, will have COVID positive patients. And as they do, and they have to really start implementing the guidelines and the quality assurance guidelines along with the infection control guidelines, they will embrace us and they will embrace you back into their building because they are still held by the original standards that were present prior to COVID, which is PDPM, which is hospital readmission prevention, which is prevent wound breakdown, which is quality measures and making sure that wounds are getting better and not worse. So all of those are still reputable citations and regulatory guidelines that they have to obey. And so currently they're not doing it, and we know that. But I do anticipate most of this to evaporate literally by the end of the month as the enforcement guidelines for reporting are put in place. Alfred asks, was any of those COVID-19s that were readmitted tested positive again? Yeah, great question. It wasn't written in this article that any of them were COVID positive again. It showed COVID negative. But I did come across a different article saying that they had at least one patient who was readmitted that was COVID positive again, but it could not give any explanation how. I'll search for that article and try to include that into our next webinar. So that's one of the things that has been sort of, not clear. No one has really been able to definitively so for any readmissions that those patients have somehow converted and become positive, and with any clear reasoning. What I've seen is that they've come back symptomatic and declining, but are still registering as COVID negative. But I will do more research and share that with everyone at the next presentation. Great questions. So now let's talk about some of these clinical dermatological presentations to close out our presentation today. So as we know, we have our common symptoms: fever, cough, headache. And as you know, we've had newer symptoms that are more common that people and patients are speaking about and providers are discovering, such as myalgia, as well as asthenia, which is just basically overall weakness. And very common, they're saying on their COPD patients, that weakness is even more amplified, where they're extremely just feeling exhausted. And then of course, loss of sense of smell, and then also loss of taste, as well as diarrhea are also common symptoms that are being more reported now. I think as people understand that that is a potential symptom, they're more attentive to it and assessing for it, which is why we're seeing more of those as reportable symptoms. But one thing that really started to show now are these different variations of cutaneous manifestations of COVID-19, and otherwise known as the COVID rash. And so you'll hear it all the time, that's a COVID rash, that's a COVID rash. And so the challenge with the COVID rash is that it's not one specific type of rash. And so specifically, it's an exanthum that does occur during or after a COVID-19 infection. And actually, I need to amend that definition because there's been some cases where it has occurred slightly before other symptomologies. So as a precursor, which is not uncommon for any viral exanthems, there's different versions of viral rashes that can occur before, during, or after an infection. So COVID is really no different. But the difference is with COVID is that there's multiple variations of that presentation versus in most viral exanthems, it'll present in one form and that's it. That's consistent with the diagnosis. So either way, the rashes do tend to appear in younger people and last for several days, but more commonly that's been occurring, they're finding it in older individuals that are COVID positive, and it's becoming more and more often. So it's not uncommon, like I mentioned before, for viruses to be associated with rashes. Chickenpox is a viral infection, and you get a vesicular rash diffused all over your body. So not uncommon at all. Rashes are well known to be associated with common viral infections, including pneumonia and other versions of that. So, but like I mentioned earlier, what's interesting about COVID rash is that it's nonspecific. It comes in a lot of different shapes and forms. And so I wanted to go over it because I was doing some research and found some good documentation from the American Dermatology Association, American Board of Dermatology, as well as some in some European and Britain where they have their Board of Dermatology. So they produced some different articles that I thought were very helpful. And so I was able to identify 6 different variations that are documented between the different boards that I thought would be helpful. So number 1 is an asymmetrical chilblain-like lesion around the hands and the feet, which could be itchy or painful. It's generally found in younger patients, but it can occur in obviously older patients as well. It tends to last for about 12 days and appear later in the course of the disease, and were associated with a mild infection. So these aren't patients who were generally hospitalized. These are more patients who did have symptomologies that tended to be mild. They were managed outpatient, but they did end up with these discolorations at the distal tips of their hands and their feet that look like frostbites. And that occurred in 19% of cases from this one specific study when they did a retrospective on 375 cases. There's also a pseudo version of it, what they call the pseudo chilblain pattern. And the interesting part about this one is that this was more common across the board. Almost 60% of cases would end up developing this sort of more diffused version of this rash. And so, which really just spoke to the fact that most patients will develop, something in some course during their presentation. So as we start managing COVID positive patients, we want to start assessing the distal extremities and assessing the body and making sure that we don't miss any non-specific rash that might be occurring at different parts of their body. So what does that look like when you're talking about chilblain like lesions? So these are going to be lesions that kind of look like frostbites. They're hyperuremic, they're hyperpigmented, darkened discolorations at the distal extremities. And you can see it in picture A, B, and C. And then what makes it interesting is they also occur on pressure points. So once again, if you have a COVID positive patient, and they have a wound potentially, or what appears to be a stage 1 or a DTI occurring at a heel or at a pressure point, you may be highly suspicious that it may be COVID related, and it may not actually be a pressure related injury, but more of a dermatological case. And I'll show you another variation here of what it looks like when it starts to actually resolve. You have the areas of hypererythema, you have elevations in skin, and then over time, as it improves, you get this hyperpigmentation, this sort of dull, dusky appearance of the skin located over the area where you had the hyperemia. So let's make sure there's no questions. Okay, good. Let's keep going. And so you also will get more of these other independent acral lesions that are crusted, indicating early necrosis as well at the distal extremities. These occur as well. They don't know if it's due to trauma that initiates it or if it just develops on its own. But I will talk about thrombosis a little bit later to kind of help show that there are some other associations that we need to think about. And here other versions of this the pseudo-Chilblain pattern. Like I mentioned, you'll get the distal extremity hyperemia. One of the things that's consistent with the pseudo version is that it can be painful when you rub it or touch it, or itchy. So it can have these different variations in presentation. And then eventually it'll start to try to resolve slowly over time. It won't advance to the more necrotic looking appearance. So another version is some patients will get small blisters that are often itchy and found over the trunk and the limbs. And it's more common in middle-aged patients, and it can last for up to about 10 days. And it'll appear, the interesting part about this version, it appears before the patient starts having symptoms. And they found that that occurred in 9% of cases. So just like I mentioned with some viral exanthems, you actually get a rash prior to the actual fever or to other symptomologies. So, and this one can last for up to 10 days, but they may actually start developing the rash prior to any other symptoms. So those are good questions to ask. You know, was this rash here before a fever, and so on. And then another thing that patients might get are vesicular eruptions. So as you know, vesicles are clear, small fluid-filled blisters that are superficial, just underneath the epidermis. And so they found that that has been occurring up to 15% of the time, and it will come with pruritus. So it'll be sort of itchy as well. And it comes not only on the hands and the feet, but also can be found at different parts of the body. The other is a very interesting rash. It's more of like a hives, otherwise known as a nettle rash. And so where you get sort of this pink or white opaque raised areas of the skin with diffuse erythema and redness and pruritus and itching that will sort of happen at various areas of the body, if not completely all over the entire body, including hands and palms of feet. And they found that to occur in 19% of the cases. And here's another version of it that looks, this version looks more just like general hives as well, but this is over the trunk. And so you'll find it or over different parts of the body as well, okay? So another one that was really, really common, 47% of the time, was this macular papular, small, flat, like little lesions all over the torso. Just basically looks like a heat rash almost. And it does generally appear later on. It doesn't come on right away. And it was more common in patients that have respiratory manifestations, shortness of breath. They might have needed to be on a vent or a respirator. And so that was more common with your ICU patients, but it did occur in 47% of cases. And it does last for about 7 days. So another important rash to sort of keep in mind. So once again, all of these are associated with COVID positive or COVID suspected or post-COVID positive patients. So another version of the macular rash, this is a flat version, so it's not the little small macular papules, it's more of these flat macules that are slightly raised and become confluent, covering different parts of the body. So as you can see, all of this is very non-specific. That's what makes the COVID rash so, I don't know if it's challenging, interesting, or difficult, or all of the above, simply because it's not well defined by one specific presentation. So the American Board of Dermatology has, they created, or the American Academy of Dermatology, they created a registry where they're trying to get every dermatologist who've ever treated a COVID positive patient to go into this registry and write down what they see, take pictures and share it and put it all, so they can find out and try to start to hone down on what really is a COVID rash and what are the different specific manifestations. But it is all over the board. This list here, once again, is another version of all the different variations that could occur, where you can get diffuse urticaria, you can get the acral ischemias, which is basically ischemia occurring at the end appendages. You can get the morbilliform rashes, the levato reticularis, where you have necrosis of the distal extremities, and I'll actually show you a version of that soon. So you get vesicular rashes, you get petechias. So it's so non-specific, which makes it kind of dangerous to deal with, because you like to be able to focus on one type of symptomology or two, but not 10 or 12. And so that's the challenge. But we hope that over the next 6 months, as databases of the different variations become isolated and sort of combed through, we may realize that maybe they're not necessarily COVID positive. They might just be more of exanthems that are just related to fever or something else, but time will tell. So nonetheless, the last one is basically necrosis, otherwise known as levato, where it occurred 6% of the time, at least in the cases that were investigated in this particular study, where you have early gangrene, where in the beginning you're going to have sort of that blotchy blue-red, opaque white skin, and then it starts to develop a small pattern at the distal tip, and then starts working its way proximately. And they find that in those cases, there were signs of poor blood circulation, obviously ended up in early gangrene presentations, and it was more common in the older population. The older the patient, the more this problem was apparent. And so the nice, so ultimately, there's the word COVID toes and COVID foot and COVID hands. There isn't, I can't really say at this point there's one specific definition for it, because people are using it as a general terminology for a lot of different variations of the presentation or different extremes of it. But ultimately, what we're talking about is preneo, which is when you just basically have distal extremity early necrosis occurring at the distal extremities. So over time, we will see what is reported, and I'll continue to share. But one thing that dermatologists are seeing is more and more cases of small clots that are occurring at the toes and the fingers, which is what's resulting in these incidences of preneo. So I mentioned earlier, viral exanthems aren't unusual. It's very normal, but the problem with COVID is that it's so non-specific, and it's not aligning with one specific type of presentation. And even worse is that you have these very specific version where you have superficial clots that are forming within the blood vessels, almost really similar to calciphylaxis, where you have necrosis at the microvascular level of the blood vessels, resulting in death, tissue necrosis of the tissue there from the dermis to the epidermis, and sometimes even into the soft tissue. So I wanted to give an example of COVID leg, COVID foot, and this was a great example. I was going to give others, but Dr. Smalta actually sent me his own image, and so I thought it was better to share his, because his was dead on. And he also sent me a video, and I'm sorry, Dr. Smalta, the video wouldn't download appropriately, but I was able to put the image up, so let's talk about it. And as you can see here, he has a patient that already had a history of arterial disease But once the patient became COVID positive and sort of went through the normal manifestation of the infection, one of the end results was COVID foot and COVID leg, right? Where now, if you notice that the patient, even though the patient already had hairlessness, already had atrophy, already had sort of skin that was cool to touch with the gradation, after being COVID and experiencing the infection and the manifestations of that, you now have distal extremity advanced necrosis, where you can see the toes, if you look at the very bottom, are now black and necrotic, where you see gangrenous set in, and then you can see the superficial necrosis at the tibia, where you have areas of just diffuse necrotic tissue. So you can have these scenarios, and with COVID, it's associated with sort of two scenarios where you have the hypercoagulopathy that's occurring, especially at the microvascular level, along with then tissue necrosis. So start paying attention to this for your patients that you see, and keep that in mind. So we will be writing due to COVID a lot, sort of, in our statements. The patient worsened due to the recent COVID infection, or the patient's symptoms or conditions worsened due to their COVID infection. So it will not be an uncommon diagnosis that we'll be using as an adjunct diagnosis to the current conditions that we're managing, especially when they worsen. So keep that in mind, be mindful of it, and use it as needed. And we'll talk more about it in the future, but don't feel uncomfortable associating the worsening scenario of your patient with their COVID infection, okay? All right, so I'll go over a few more scenarios before we close out. Sorry, I know I'm already over time. So thrombosis has been really higher and higher cases of thrombosis have been reported, where there's high rates of DVTs and PEs, and a lot of critically ill patients. So once again, running to that hypercoagulopathy that's occurring with COVID. And so what's happening now, a lot of patients, when they get into the hospital, are being put on low molecular weight heparin as a preventive measure, just to make sure that they don't end up with a DVT or with a PE during their hospitalization. Also, because of that, we have increased cases of MIs and CVAs that are occurring, more frequently being reported. One of the things that some of the data has been sort of questioning is, are there really more cases due to COVID-19, or is it because these are just more acute scenarios, and so you just have a higher incidence because you have this very high population of patients? But what they've noticed that in spite of prophylaxis, you still have a high occurrence, and that's really what's the kicker. But once again, not enough data yet. They're still researching, and I will share as we move forward. CNS symptomologies, a lot of more cases of encephalopathy and encephalitis that's occurring with COVID positive patients. Now, different reasons for that: fever, just ongoing uncontrolled fever, also infection as they become more immunocompromised, resulting in the encephalitis. So that's something that's been more common, that's been occurring, especially with patients who end up dying. And also with the very ill patients, they've noticed that there's been a higher case of patients who obviously are treated empirically with antibiotics upon admission, and they're thinking that there's actually potentially even more cases of infection, but they've been able to circumvent it with prophylactic antibiotic therapy. But a huge concern is pulmonary aspergillosis, which is a fungal infection of the lungs occurring in higher amounts. And they found that when they did the Wuhan study and looked back, 10 to 20% of incidences of bacterial and fungal infection was occurring in patients who died. So they're concerned that those numbers may repeat themselves here. So as we conclude our presentation and as we continue to move forward, there is a lot to think about, regulatory and clinical. I know that I'm throwing a lot at you guys at once. And, we'll try to review as needed and kind of, keep the information fresh. But we have to stay up to date as much as possible, considering all that's happening in our space. Believe it or not, you guys are the most knowledgeable people that walk in there. The nursing homes are just, they're busy just trying to, keep their head above water. And the information that you learn, please share with your nurses, with your staff that you work with the DON, with the leadership administrators and regional managers, because it's really helpful in keeping them sort of in line, whether it's regulatory information or clinical information. And the most important thing for yourself and for the people you work with, do not stress, don't stress out. Try to always make sure that you build a team in your facilities. I know I end with this slide a lot, but I'm not going to stop because I think it's just a great slide that talks about just working together and helping each other. And in doing so, you can always, be successful, and we know we can always all weather the storm. And so, and most importantly, all of us, we have to make sure critically that we're still following infection control protocols. We will never, I do not want any of us to ever be implemented or implicated as not following infection control protocols in the facility. They have nurses who that's their job 24 hours a day. They're watching us. So please wash your hands in between every patient and as much as you can, just to make sure that you're trying to prevent any infection. Make sure you wear your PPEs when you walk in the building. Make sure that your patients who are COVID positive or suspected are also masked. That's really important. Make sure your nurse is wearing a mask. That's also important because you guys are in close contact and working together. So you want to be safe together as a team. Really, really important. And then, of course, use hand sanitizers. We'll be sending out more on this next shipment to make sure that everybody has more to keep in their car. So when you do leave the building and you just need to keep your hands clean and you don't have water available, you have hand sanitizer right there to help you. And so it has a maximum amount of ethanol in it, which will give you the highest kill rate of any hand sanitizer out there. So use it, and also has hyaluronic acid in it, so it won't dry out your hands. So it's a great brand, so continue to use it, please. And so stay positive. This is the right kind of infection that we do want to be a vector for and spread around, and that's that positive energy. If you keep spreading it to everyone around you, all of those unhappy faces and stressed out faces will become positive as you then spread it to everyone else. That's the right kind of infection that we want to keep doing. So please continue to do so. Don't forget to be a leader in your facilities and support your nurses during Nurses Week and send out positive vibes to them as well, and give them a lot of big ups and a lot of positive reinforcement for all the hard work they're doing. That's what leaders do. And so we know that all of you guys are leaders, and we continue to encourage you to do so in all of your facilities. All right. Any questions before we close out? Oh, there's a few. Let's see. Let's see. Jada asks, regarding PPEs, are still recommended to wear surgical mask over? Yes, over your N95 or shields over the N95. If you can wear all three, you're winning. If you have shields, I think I got some shields. I need to give it to KC to send out. The best is number one, your N95, then your surgical mask on top of that. And then if you get a shield or you're requesting one, and you have access to one, you wear your shield on top of that. That will give you the ultimate level of protection. So always wear it whenever you have it. Dr. God, I forgot who it was, sent me a great video that I'll share on the next webinar on how to create your own mask. It was really cool. Avatar asked, excellent, highly informative presentation. Oh, thank you very much, Avatar. And Sharia, think positive, test negative. I love that. That is an awesome statement. I will steal that and use that at our next webinar. And so that's a great conclusion to today's presentation. Sharia said, think positive and test negative. So that's a great statement to end on. Think positive and test negative. Thank you all very much for attending. Thank you for your time. I know East Coasters is late, so we do appreciate you showing up. and use this information. You can watch this video again. If you have any questions on the rashes, call me or text me so we can go over it, and I can help you with any cases you have. And you should all have my cell number, so reach out at your convenience. Always remember, texting is best. That's the fastest way. Thanks again. Have a great evening, and talk to everyone later. Talk to you guys soon. Have a great night.